Ron Witteles, Mike Gibson coming to you live from ACC 2025, and we're talking about amyloid and some of the other cardiac manifestations like arrhythmias, in particular AFib. Ron, talk to us about that intersection of AFib and amyloid.
Sure. So atrial fibrillation is extraordinarily common in ATTR amyloidosis. You'll see some in AL, but in ATTR amyloidosis, it's extremely common. Literally somewhere between 65 to 70% of patients with ATTR amyloidosis have current or past atrial fibrillation. It's for practitioners who care for amyloid patients, you'll see that it matters for a lot of them. A lot of them are symptomatic, and it really gets into this question of whether you should pursue rhythm control or not. Now there's the other part of it, which is anticoagulation, which I'd emphasize is extraordinarily important. Obviously we think about that in most of our atrial fibrillation patients, far more important in our ATTR cardiomyopathy patients. They have such diseased atria, very high rate of thrombus formation, very high rate of stroke without anticoagulation.
Any special considerations in these patients? I mean, there's always been I don't know if it's an urban legend or true about DIG and amyloid. What about special considerations in their management?
Yeah, it's a little bit of both. It's both an urban legend and true. So as you're getting at, there's some truth to the fact. Digoxin binds to amyloid fibrils, so you can have normal serum levels and get local toxicity in the heart. So theoretically, you've always heard don't use digoxin in amyloid patients, period. For AL, that's more true than for ATTR. I would say if you need to use it cautiously for rate control, it's reasonable. Frankly, most of the time you don't need it because their AV nodes are diseased enough that many have normal rates even without any rate control agents. I certainly wouldn't use it for heart failure. So what other considerations? So I was mentioning anticoagulation. The general consensus is to perform a TEE before cardioversion in every single time you're doing a cardioversion in an amyloid patient. That has been questioned some. Is it a little bit of overkill? Are some of these tiny thrombi old, not going to go anywhere? And are we preventing rhythm control in patients who could otherwise benefit? But the general theme is do a TEE beforehand. Then there's the rhythm control question. Should you do it? Again, the conventional wisdom is ablation, atrial fibrillation ablation is not successful in these patients because their atria are so diseased. I actually don't completely agree with that.
Okay.
I would say that I send a good number of patients for atrial fibrillation. Electrophysiologists are never happy getting an amyloid patient for ablation. It's like sending somebody to a cardiothoracic surgeon for a pericardial stripping. They might do it, but they're not happy about it. An electrophysiologist is not happy to be doing it because the atria are so diseased. But I can say that both anecdotally as well as the limited evidence is out there, it can make a difference, and sinus rhythm can be so beneficial symptomatically for these patients.
Great. Ron, thanks for joining us. Thanks for the update. I learned a lot. And thanks to all of you for joining us here live from ACC 2025.